Before moving to the next session, we will give the prizes for the people who answered the questions. I request Dr. Panir Selvam sir to give the prizes. Dr. Muhammad Nabi, Srini Prakash and Sarath Kumar.
Our second session is going to be about deconstructing the phenomenology of OCRDs, honey traps while presenting an OCD case in exams. Our speaker is Dr. Noorul Hasan sir, MD, Additional Consultant, Sneka Mind Care Hospital, Tirunelveli.
Our chairpersons are Dr. J. Babu Bala Singh and Dr. B. Gurumurthy. Dr. J. Babu Bala Singh had graduated from the Institute of Mental Health, Chennai. He is working in KMCH, PSG IMSR, Coimbatore before joining the government service, and is presently in Thiruvarur Medical College. We welcome you to the dais, sir. Next chairperson is Dr. B. Gurumurthy. He is currently working as a Senior Assistant Professor of Psychiatry in Coimbatore Medical College and Hospital. And he did his MBBS in Madurai Medical College and his PG MD Psychiatry in Institute of Mental Health, Madras Medical College. We welcome you to the dais, sir. We ask you to introduce our speaker.
Now we hand over the mic to the chairpersons.
So OCD is one of the, whenever you get a case of OCD, it usually is a long case. And it has a wide variety of discussion where you can have in OCDs. Especially they can talk about the phenomenology, the clinical features, comorbidities, the drug therapies, choosing the right drug, and the whole lot of psychotherapies that are involved here. So it is interesting to know more about OCD. And the word honey trap, I was curious to know what is a honey trap. So it is in the Bond movies you see, no? To get information, they send a female spy. That spy is called honey trap. And I think Dr. Noorul Hasan will bring the honey traps and OCD, and hope this is going to be a very lively session. I hand over to my other chapters.
Thank you, sir. It gives me immense pleasure to chair the session of my esteemed student, Dr. Noorul Hasan. So I thank the organizers and Dr. Noorul for giving me this opportunity. Dr. Noorul Hasan is an MBBS graduate from Thothukudi Medical College, and he did his MD Psychiatry in NIMHANS, Bangalore. And he did his senior resident at Department of Community and Mental Health, NIMHANS, in 2020. And since 2021, he is being as a consultant psychiatrist at Sneka Mind Care Hospital, Tirunelveli. His areas of interest are biological psychiatry, OCD and psychotherapy, geriatric psychiatry, genetics, neurocognition, community mental health, and ECT and non-invasive brain stimulation. He has 3 national level publications, and he has presented multiple papers at national and international conferences. His major works are on treatment-resistant OCD and glutamatergic augmentation. He has written many articles in newspapers and articles and journals. And the topic to me is an interesting one. Actually, phenomenology, we have been taught that it is a study of the essence of things. Whereas deconstruction, in philosophical terms, it is not concerned with the essence of things, it is concerned with the context. So it was put forth by Jacques Derrida in a postmodern philosophical context. So having said this, to the obsession in literal meaning, it means that to possess and to occupy. So in the next few minutes, I hand over the mic to Dr. Noorul to take possession of this postgraduates and enlighten to deconstruct the OCRD symptoms. Thank you.
So my topic for the today's discussion is on deconstructing the phenomenology of OCRDs and honey traps while presenting an OCD case in exams. So this will not be a part and part presentation, the one which cover the deconstruction, other which cover the honey trap, not like that. So we'll together cover both in a flow. So I can present this topic in a 2 type of way. One way, I can just theoretically teach each chapter of OCRD under DSM and ICD And at the end, I will see you all sleeping, and we can discuss whether yarning is a compulsion or impulsion. In that way, we will not go. Rather, we'll take a different route, conceptualizing OCRDs, and we will understand the cutting differences between a closely related OCRD. Okay, in that way, we will conduct the discussion. Okay, now, so don't take notes. I will share my slides at the end of the session. Okay, just listen, because active listening is needed in this topic. Because the first topic was in a complete conceptual drive, and my topic is on a complete phenomenological and definition drive. So just you need to listen actively for that. Yeah. So part 1. In exam, you'll be given a long case as schizophrenia, bipolar disorder, RDD, and childhood and addiction disorders. If this is the case, the examiners will go in a different pathways from psychopathology, classification and diagnosis, management, pharmacology, psychotherapy, rehabilitation, forensic, neurobiology, and neuropsychiatric aspects. So in any ways, you will be taken into the discussion. It applies to all access 1 disorders. When it comes to OCD, you need to know the definition of obsession, compulsion, Y box, insight, avoidance behavior, safety behavior, proxy compulsion, family accommodation. These are the 6-7 terminologies that you need to remember, along with the diagnosis and flowchart for management. So hope you all familiar with that flowchart from clinical practice guidelines by the OCD team from NIMHANS, right? So this too is enough to present the case. Got it? But if you are given a case which has a comorbid OCD, then you will be in a trap. Okay? So they will jump into phenomenology and its psychopathology or neuropsychology or cognition, whatever way they may take. Hope I am not too judgmental about the examiners, but these are my predictions. So where they will go? So here you have a list of chapters which has a similar phenomenology in terms of compulsion or inhibitory control in terms of OCD, closely relating to OCD. Okay? Example, OCD, tic disorder, addiction, behavioral addiction, eating disorder. This all will come under the spectrum of impulsivity, compulsivity from the classical literature or recent literature. Why this all come under same roof? Because we have motor disinhibition and stereotyping, rigid strategies or cognitive inflexibility, inappropriate persistence of an habit, impaired ability to stop a response or a sequence. So because of this concept, couple of disorders can lie together under the spectrum of OCRD. Okay? So here, instead of understanding the theory or the treatment part, example, you are given a case of schizophrenia, just listening to their history will be enough to understand their diagnosis. Okay? But in terms of comorbid disorders with OCRD, the active clarification is needed with a correct question at the correct time. If you are unable to do that, then you will be in a confusion of whether it is a OCRD, OCD, or the part of other OCRD. Okay? Now, OCRD, I will give an overview of the OCRDs. The classification system from DSM and ICD-11. For DSM, the OCRDs are 5. The token Bosch. Okay, you remember in this way. I will use 4 or 5 code words like this. Okay, that will be helpful for your exam to write theory and for practical discussions. The token Bosch can be expanded as trichotillomania, obsessive compulsive disorder, body dysmorphic disorder, skin picking disorder, and hoarding disorder. The 5. DSM 5, we have 5. In ICD-11, we don't have 11, rather we have 8. So the 5 will be the same. Okay, the 5 will be, the same, and the next 3 will be different. So that includes hypochondriasis, olfactory reference disorder, and tic disorder. Here, tic disorder is very unique. It is classified elsewhere between the neurodevelopmental and OCRD. Okay? Now, So these are the areas there we are going to discuss how to clear the confusion within ourselves. Now, why it is tricky? So the OCRD spectrum disorder itself a galaxy, okay? There are a couple of disorders which are very closely related. So they lie near to each other in the galaxy. There are some disorders which are not highly related to each other, so they will lie apart in the galaxy, but they will lie in the galaxy itself. Okay? So it is our responsibility to differentiate what phenomenology of OCRD it is. And why do we need to clarify? So I have explanation at the end of my presentation. Okay? So you look at this image. So the center part is OCD. The parallel areas which have a similar phenomenology of impulsivity, compulsivity are occurring at the circumference. From personality, somatic hypochondriasis and BDD, depression, eating disorder, schizoobsessive, tic disorder, neurological disorder and impulse control disorder. So these are highly crumbled each other. Now it's our duty to differentiate it. How are you going to do? We'll go. The understanding of phenomenology adds so much significance to the classificative system. For example, trichotillomania was initially coined by the dermatologist, note, the dermatologist named Francois in 1889. Later recognized, so initially recognized as a skin condition, later it was taken into consideration as a psychiatric disorder from DSM-3 revision. As an impulse control disorder, otherwise not specified. Then impulse control disorder proper from DSM-4. Then in view of repetitiveness, it was classified again under DSM-5 and 11 under the spectrum of OCRDs. But still we have some confusion. Why? Whether the trichotillomania act is preceded by an obsession or not, or any preoccupation or not. So anyone want to answer? Anyone? Does this trichotillomania actually preceded by a thought or not? It acts as an impulse or preceded by some thought or preoccupation. So what's your opinion on this? Sorry? So yeah, thought is preceded. Anyone? Impulse, yes. So after all this struggling in classification, we have a convenient understanding of trichotillomania. It has both. It can act as an impulse. It acts with a preceding thought also. So it acts as an impulse without the awareness of the individual, then that is called automatic type. And if it is occurring with the awareness, preceded by sadness, stress or boredom, then you can coin that as a focused TTM. Got it? So the phenomenology from dermatology to psychiatry with different version. So understanding the phenomenology will make you to keep the disorder the particular position that will help you in treatment implication or psychotherapy implication. So that is the motto why we are discussing this topic here. Now, the first slide, so this will be a very helpful slide for you in exams. So this slide describes OCD, obsessive compulsive disorder, in a simpler way. Okay? So we have pointer. So we have OCD, obsession and compulsion as a part of OCD. Okay. Now we have to classify the OC in terms of form and in terms of content. What is form? The form refers to structure of the OC symptom, and the content refers to the meaning inferred by the OC symptom. So according to the structure, you can classify obsession into 4 or 5 varieties. So you remember like 5D, okay? The F is fear, I is imagery, then doubt, then impulse, and along with some magical thinking or obsessive thinking. So you can classify obsession in terms of form into 5 or 6. In terms of compulsion, you can classify that into 2, the yielding and controlling compulsions. Anyone from the audience who want to differentiate what is an yielding compulsion and what is a controlling compulsion? Anyone? Just blurt out, no problem. I am not the examiner. Sorry? No, it is not. Because I'm already discussing OCD. So already it is ego dystonic, right? Then okay. I am concerned with cleanliness. I am having thoughts about my cleanliness. I am washing my hands. Do you feel these two entities are congruent to each other? Got it? Now, I have one patient. He was saying, whenever I feel my mother to going for hospital, I develop thoughts related to some danger happening to my mother. Okay? Whenever I get this thought, I will just tap the wooden 3 times, 1, 2, 3 in odd numbers. Here, obsession and the compulsion are not congruent to each other, right? They are different. Here, concern about cleanliness and you are washing. Here, the overestimation of threat and you are doing tapping. They are not congruent. Got it? The first one is the yielding and the second one is controlling compulsion. Are you clear? So the first part over, 5D and 2 types of compulsion. Now we will move into the content. So according to the content, the OC can be divided into 5. Okay, the dicer is a code word. So dirt and contamination, aggression, inanimate and personal. Here it comes the symmetry and all. Then sexual, then religious. So 5D, then dicer. Okay, this is for your exam purpose. For evaluating a case with OCD, you need to remember this domains. Okay, the human CFSF will be the code word. H is hoarding, then cleaning, symmetry and forbidden thoughts. For F, you have a ADHD self-report scale, right? ASRS. That is the code word. Aggression, sexual, religion and somatic type. Got it? So with this single slide, you can completely evaluate a case of OCD in terms of the history taking. Okay, and you can answer bit from the same slide if any phenomenological question is asked from Salman and Akhtar. Okay, so this slide is from the article by Salman and Akhtar. It's a very previous article, old article. You all have to go through Salman and Akhtar article on this phenomenology and other one for the clinical practice guidelines. Okay, so this slide is clear. Can I move then? Yeah. Now, here now we have to understand what is impulsivity, what is compulsivity. I don't have any code word, just read and understand. Okay, for impulsivity, what are the characters? Repetitive acts with pleasurable consequence, not preceded by obsession and preoccupation, gratifying immediate reward, egocentric and abrupt carefree acts. These are simply impulse or abrupt carefree acts which has these characters. Opposite to that, in compulsivity, these are all compensatory motor or mental acts. Note, usually preceded by obsessions. At times, at times isolated phenomenological entity alone. So you will find compulsion, sometimes you are unable to evaluate obsession in it. Acts are driven to reduce the anxiety instead of pleasure seeking here. Okay? And the fourth one, they are simply careful acts. So I am washing my hands because of the carefulness that I am taking. So you have to understand this in very clear way. Impulsivity and compulsivity are completely different. Am I right? Impulsivity and compulsivity are completely different. In an established OCD case, can impulsivity happen? Anyone? Is there a possibility that impulsion one day become a compulsion and compulsion one day become an impulsion? Is it possible? Possible? Correct now? Yes, it is possible. Not in every time, but rarely possible because the impulsivity and compulsivity are in an orthogonal relation with each other. Okay? So you will be repeating one act because of the obsession. At the height of severity of the illness, there will be no obsession, you suddenly simply repeat. Example, touching compulsion, if you ask, people will not tell the obsession, rather, I just thought of touching. So one day it will become an impulse. So these are in orthogonal relationship. There will be controversy with this concept, but for understanding this is very important. Okay? Now, so how OCD occurs? So we have to understand this cognition behind this so that we can do a better therapy in the future for any OCRD. See, premotor cortex and putamen. They are very important for maintaining a habitual act. Okay? Got it? So example, someone is in dependence, okay, simply telling them not to do the substance use behavior will not help them, right? Unless you impart a learning through motivation. So, because these are habitual acts that will recur and again. So this is a function or aberrancy in the premotor cortex and putamen. Okay. Now, when it comes to OC, we have prefrontal area, there is an issue in error monitoring or heightened error monitoring, okay, that will lead to a motor habitual act followed by reward. In between, there is a autonomic arousal, right? So there will be an obsession followed by an autonomic arousal or anxiety, then you do compulsion. So you hope you understand the circuit, right? Prefrontal, premotor plus putamen, then reward. Got it? Any issue in any of this, be it a reward, because in eating disorder, what do you find? In binge eating or bulimia nervosa, you have issues in gratifying the reward. So you go on eating it. So reward, if there's an issue in reward, that will lead to OCRD. If there's an issue in cognitive control, that means inhibitory control, set shifting is lost, then you have OCD. Then habitual behaviors because of the aberrancy in premotor cortex and putamen. So the driving factor is the limbic circuit because of the anxiety they are doing the act. You understand this paradigm? Yeah. Now, so this I already explained. Here the cognitive concept of OCD is hyperactivity of habit formation system. So the compulsions are primary and the obsessions are secondary rationalization for the compulsion. You got it? A different mode. Because you cannot go in a prospective way when you analyze a fMRI. Rather, you have to take a retrospective step, how it happened. முட்டையிலிருந்து கோழியா கோழியிலிருந்து முட்டையாங்கிற மாதிரி முதல்ல அப்சஷனா கம்பல்ஷனா. So we have different type of explanation, one from the phenomenological historical perspective and other from the cognitive perspective. You got it? Yeah. Stepping into the unique phenomenologies in OCD, the confusing areas. Okay? So number one, sensory phenomenon. See, through my experience or understanding, so I encountered many people from my classmates or seniors, even a couple of residents from here. People have different understanding of for sensory phenomenon in a variety of ways. So if you ask you will tell, you describe sensory phenomenon in a different way. If you ask you will tell in a describe in a different way. So this is a very confusing area. So now we will deconstruct one by one. Here, as I told, altered corollary discharge and enhanced error detection in the brain circuits that will lead to persistently inaccurate sensory predictions according to subjective standards. Note this. This will lead to a compulsive act. You got it? Simply, so you are seeing the same image, the first one, though you know it is the image of this woman, still you want to confirm it. Okay, so that aberrancy in error detection or incompleteness will lead to a compulsion to get a correct image of what happened. Here, the sense of imperfection or sense of incompleteness that will lead to repetitive behaviors. The sense of incompleteness, inability in closure. These are all the description of obsession, right? Incompleteness or inability to go for a closure. Okay, so if you groom that sense of incompleteness with a sensory modality, the outcome will be sensory phenomenon. Okay, you understand now? Yeah, the sense of imperfection in sensory modality as a bodily senses or mental sensation in terms of urges, okay, that will lead to two things. The sensory phenomenon will lead to two things, tic disorder and other one is compulsion. Got it? sense of incompleteness, you are going to groom that with sensory modality, you will get a sensory phenomenon here. That will lead to two types of neutralizing behavior. One is a tic and other is a compulsion. Okay? This is not possible with every context of tic disorder. CTP describes tic disorder as a involuntary or semi-voluntary. That means involuntary also possible in that context, correct? So now we will move on. How to differentiate between tic and compulsion. Whether the person is having a tic with motor act as a compulsion or as a tic per se. Two differences you have to remember. Number one, the cognition, autonomic anxiety and less sensory phenomenon. This is the characteristic of OCD. Low cognitions, okay, low autonomic anxiety and high sensory phenomenon is the reason behind tic disorder. So, this is the cutting differentiation to deconstruct between tic disorder and OCD. You got it? So, if the patient is having the high cognition, that in terms of multiple distortions, autonomic anxiety and less sensory phenomenon, then your diagnosis would be OCD. If it is in the other way around, then it is a tic disorder. But the pattern should be of, coordinated single muscle group or multiple muscle group motor act, or else this discussion not needed here. Got it? Now, so we are discussing phenomenology in different perspective. Here, treating one axis 1 disorder, okay, the ADHD, treating one axis 1 disorder, ADHD, will give rise to another axis 1 disorder of different phenomenology. For example, in ADHD, neurobiologically speaking, low dopamine 1 receptor and alpha 2 activity that causes low signal and high noise. This is the neurobiological understanding of ADHD. When you treat this with dopamine transport inhibitor and norepinephrine transport inhibitor, okay, you will get a modest action at the alpha 2A and dopamine. You are treating an ADHD. If you overtreat, you will get tic disorder. So how will you reverse tic disorder? By giving a dopamine antagonist. So it's a very unique spectrum, but treating one axis 1 disorder giving rise to another axis 1 disorder of unique and different phenomenology. Interesting, right? Neurobiology. Amazing. Now, OCD with ADHD. Okay, anxiety disorder with ADHD. Which is more worse or have a guarded prognosis? I'm asking introversion with OCD and extroversion with OCD. Which is very difficult or has a bad prognosis? Everyone will come up with the answer of introversion and OCD. But the answer is actually extroversion. They have already issues in their attention. Okay, I am having attention issue, but I am not carrying with that. I am going on to other task. Now OCD is merged into it. I have severe attention issue, goes on doing multiple acts. Now I have to do so much of reassurance and compulsion. So this combination is actually a bit difficult in terms of prognosis. You got the idea behind this? Yeah, thank you. Now, the second confusion, the pathological slowness, is very easy to deconstruct. In OCD, there will be the primary obsessional slowness, there will be extreme need to perform the task with exact details. So they will do the task in a very structured and slow way. Okay? The idea behind this is extreme perfectionism. So they are doing the task with a slow pace. This is the pattern of primary obsessional slowness. Okay? But if you have other associated symptoms of OC, then you can easily diagnose, okay, the slowness is due to OCD. Correct na? But if it is a primary obsessional slowness, then you have to tease out between whether it is a primary obsessional slowness, negative symptom of schizophrenia, or catatonia. Take out all the scales, clarify one by one, look for the features and finalize. So here, the patient should be amenable to explain why I am slow. if the same issue, if you are encountering with the children of autism, here it is difficult. They have issues in explaining it. Why I am slow? They will not explain. They are very kind of rigid. And they may explain obsession in a different way. Yeah, I hear voices to be slow until this time. So we don't know whether they are explaining the obsession per se or the OCD per se. So, though it is very easy to differentiate, if there is a adjoining comorbid neurodevelopmental disorder, again that will give you a tough task to clarify the phenomenology. Now, this is one case that we have very recently seen. So I think me and Sarah has a debate for this case. Okay, a case of schizophrenia. Okay, started from cognitive dullness, then later emerged into schizophrenia. Treated, off treatment for the last 6 months, now relapsed. She had hearing of voices. Then later we came to know, she says that, I don't know, something is compelling me to do the things again and again. If mother is switching on the light, then I will tell off the light. If she is switching on the light, then I will tell the mother to off the light. Then it tells me to wash my hands repetitively again and again. And ask the person to be in a particular posture while walking. So it looks like OCD, right? Correct na? It looks like OCD, clear OCD. Yeah? The problem is, you have to again clarify, it is a thought or a voice. Difficult to deconstruct in this area. Again, it's your own thought or someone's thought. I don't know, sometimes it is coming in this way, sometimes I feel it is my thought. Now, we have to apply the ideas that we have taken from the money heist. So, what if it fails? So, now I am asking, so if you don't do the compulsion, what will happen? So, here the explanation comes. If I don't do the compulsion, he or she will throttle me and kill me by today night. Okay, so insight issue in terms of differentiating it is my thought or someone's thought. Insight issue in differentiating whether the obsession will come, pakka will happen in the future or not. Insight issue in terms of if I don't do compulsion, what will happen? So you have to check the insight in all the three parts. You will get an idea whether are we dealing with an OCD or schizophrenia or in a better way schizo-obsessive. Okay. If it is institute, discussion will go on everyday basis. Okay. Until the resident is burned out with the explanation. If it is a private setup, we will miss the patient, better start a SSRI along with that. Okay. Both can be okay. Right. But you should be clear, patient didn't have a SSRI induced switch in the past. Clarify that. And this is not a bipolar disorder. Be clear with that. So this is about insight related to OCD. So trichotillomania I have already discussed, so I am skipping this slide. In body-focused repetitive behaviors, we have three entities. The trichotillomania, skin-picking disorder or lip-biting disorder. Okay, these are called compulsive grooming disorders or neural habits, we can say. How do we understand whether it is a OCD or not an OCD? See here. So I have made this diagram. One is for obsession and another is for compulsion. Okay. In the obsession area, we didn't get clear obsessions per se. Sometimes it is preceded by emotional state, anxiety, boredom, or ongoing stressor. Sometimes no clear preceding thoughts. Okay. But that will lead to a patterned motor act in terms of trichotillomania or skin picking. So here we are not getting an proper obsession, rather some emotional states determines it. So this is not a case of OCRD. So between OCD and BFRDs, they lie distant between each other in the galaxy, so it's very easy to differentiate. But the sensory phenomenon, the poor insight OCD are very close to each other. We have to sit and the term monomania, partial insanity, Swanks neurose.
Hypochondriasis, sir?
Hypochondriasis. No, any other answers? Yes, OCD. Done. Madam, your name, ma'am? Kalai Selvi. Okay. Second question, which of the following is called as compulsive grooming disorders? That I already told in the session. Okay, everyone told, so no prizes for this. And the third one, self-hugging stereotype. This I kept this. Smith, Megan. Okay, right. So for the session, 2 backed by this Madam Kalai Selvi. Okay. So I specifically kept this stereotype E because we will be confused with the tick or stereotype E, central or peripheral. So that I kept this. Okay. Yeah. Thanks a lot.
Thank you so much, sir, for enlightening us about OCRDs.
For chairpersons.
So it was, I think you are all awake, and no one would have, with a second you would have slept. And it was a very fluently, and I think he had added a lot of mnemonics for postgraduates. I think it was a wonderful thing. And regarding the proxy compulsions, I too came across one such case, a case of eating disorder, where this particular girl was a teenager. She totally started restricting food intake, and she forced her mother to take all the food. So, she used to say, eat 2 idlis, 2 hours kadichu marudiyum saapdu. So she kept on insisting her mother to take food. So whatever she has, and she had a restricted type of eating disorder. And I think Sir has rightly pointed out. And apart from that, there are a lot of compulsions, I think, as a postgraduate. The one important thing he has highlighted, listen very keenly to what the patient says. The compulsions might not come just like that. I think you need to dwell. Even this counting compulsions can be there, the number of tiles. And that can be linked to some delusions. It goes like that. So, and Dr. Noorul has highlighted each and everything here. I think it would be, PGs would have been benefited. And I think you would be having a lot of questions now. I think you can shoot them with all the questions.
Hope there is no question because it's not about theory, it's about clinical practice. Okay. Yeah.
So during this COVID pandemic, I think what I probably you would have also, many of the seniors would have seen, a lot of young children had this, they came with a lot of obsessions. And especially this obsession was related to the death of their parents, something related to health and well-being. And I think, can you give any light about it?
Yes, sir. Actually, there was a separate study done by Dr. Lavanya Sharma between the 2020 March to 2021 end. So they tried getting so much historical inputs from all the patients they met in the OP and in the teleconsultation. So the finding was not what we expected. The finding was like the COVID has not increased the OCD or not decreased the OCD, almost equal. But in terms of OCD patients who are already diagnosed OCD, they have a significant fury of symptoms during the times of COVID. And the second thing, sir, children, so when we actually look, retrospect the IP admissions in adolescent age group, if you trace from 2008 to 2022, the rise in IP admission for children with behavioral disturbances actually started from a point between 2010 to 11. So what inference are we taking from this is, so that was the era we have first started using the Facebook. Before that we were using Orkut, and it was not testing the time. Then later Facebook came, then the evolution of other social media, now it is Insta. So this rise in social media usage are the base for the children to expose to so much of the catastrophizing contents. So that is leading to the worsening of the OC symptoms in the children, though not to the diagnosable type, but it has affected their behavior to a greater extent. There is one documentary in Netflix called Great Hack. So you can go through that. So how this social media era affected the childhood behavior. So I think that will give you some hint how the adolescents are prone for this behavioral disturbances during the OCD, in the COVID time.
Any other questions?
I think we'll get ready for the
So at the
inauguration.
end of
I
the
think.
session, to conclude, clarity and precision, these are the words I can use to describe Noorul's presentation.
Thank you, sir.
I could see a good teacher in the making. He has evinced much interest in presenting this topic. From honey's trap to devil's trap, I think PGs were possessed for the previous 45 minutes. Thanks, Dr. Noorul, for the wonderful presentation. Certain points are worth reiterating, especially for the postgraduates. The slide on the difference between tics and OCDs, and the form and content, and the last slide on the regarding the roadmap to deconstruct OCDs. All these are worth from the exam point of view. So thank you for the patient hearing. Over to the organizers.
Thank you. We now request the chairpersons to honor the speaker, Dr. Noorul Hasan. Now I request Dr. Malepan sir to honor Dr. Gurumurthy. We will start the inaugural function after the short tea break.